Hey guys, so in this video I am going to start about the developmental dysplasia of hip. And what is developmental dysplasia of hip? That is subluxation or dislocation of femoral head, means head of the femur, from the acetabulum. So we have seen the two disorder, that is part 3, in which there is necrosis of the head of the femur is happening, and in slipped epiphysis, in which there is actually no slippage of the epiphysis, but due to growth of the physis it is appearing like that epiphysis is slipping. So now it is also the disorder of the hip, in which femur of the head is affecting, but in this there is subluxation or dislocation that is happening. Now what are the risk factor and the pathogenesis? So before birth, at the time of birth, and postnatal, or you can say after birth. So there are various theories that people are saying this is the reason. So before birth it is mainly due to oligohydramnios, intrauterine packing defect, and high relaxing levels. Now at birth is due to malpresentation. So mainly it is due to bridge, in which there is extended knee and legs. And in postnatal, so if you carry the baby, hips and knees extended, which will lead to DDH. Now statistics say that it is more common in the female. So female to male ratio is 1 7:1, and bilaterality is 20%, and it is more common in the left hip than bilateral than right one. So right is actually, we can say, the less than 20%, and more commonly seen in the Western culture than the Asian, due to their technique of holding the baby. So there are 5 F, that is female child, firstborn female of the family, if there is family history, if fair complexion, that is Western, and faulty uterine position. So this is the 5 F, and there are mainly 3 types, that it can be shallow, means acetabulum can be shallow, or it can be sloping like this, or it can be convex, so like this. What will happen due to this? That upward and lateral dislocation of head of femur. So here it is upward and lateral. In previous we have seen that the epiphysis is going posterior and medial, and here it is upward and lateral dislocation of the head of the femur. So the sides we have to remember. I don't know what is the way by which I can remember this, but I'm just trying. So head of the femur, it is upward and lateral dislocation, and how are actually we are remembering this by maybe upward and lateral. Yeah, so outer and upward quadrant dislocation we can see in the Shelton's line, that's why. And the gait will be shortening, followed by lurching. So what will you see in the clinical presentation? So first we have to identify the risk factor, that is asymmetrical skin crease will be seen on the thigh and gluteal fold. So in the skin, thigh and gluteal fold. And there are various tests to check for the DDH. First is ortholanus test, in which we are abducting and pulling the hip joint and checking the clunk of entry. Ortholanus test. Now Barlow test, in which we are pushing plus adduction. बोला है डॉक्टर. Oh.
Albo wala na akong magyari. Wala ba kung count ka na?